Hello, my name is Doyoung Park from University of Ulsan College of Medicine, Asan Medical Center, Seoul, South Korea. I'm currently a professor of gastroenterology. I am honored to share our study, comparison of EUS-guided ablation and surgical resection for non-functioning small pancreatic neuroendocrine tumor, a propensity score matching study with Dr. So, who is one of the first authors.
Hi, I am Hoonsub So, working at Ulsan University Hospital. I am also glad to introduce my result to the listeners.
Dr. So, what was the aim of our study?
The incidence and prevalence of localized asymptomatic pancreatic neuroendocrine tumor, PNET, is increasing, but treatment strategies for small PNET under 2 cm are still under debate, especially for 1 to 2 cm. Some advocate wait and see, but some prefer surgery. Recent studies suggest local ablation by EUS-guided ethanol ablation or radiofrequency ablation, but there was no comparative study with surgery. Therefore, we designed a comparative study by using propensity score matching.
Yes, wait-and-see strategy with regular and frequent radiology imaging for slow-growing tumor can give too much worry or fear, especially for young adults. However, pancreatic surgery has high chance of morbidity. So I went through EUS-guided ethanol ablation as an alternative surgery for those with small PNET. Dr. So, can you explain the study design?
We retrospectively reviewed patients with a PNET who were managed by EUS-guided ethanol ablation and surgery at Asan Medical Center. Propensity score matching was performed to increase the comparability. After matching, 89 patients with each group were included for comparison.
Why did you undergo propensity score matching?
Before matching, the surgery group was associated with larger tumor size, advanced grade, and tumor was more frequently located in the body and tail compared to EUS ablation group. Therefore, we thought propensity score matching with reducing the bias of both cohorts would give more validity to the study.
What was the primary outcome and what grade system did you use to compare endoscopic procedure and surgery in this study?
The primary outcome was early and late major complications using Cleveland-Dinder grade system. Major complication was defined as Cleveland-Dinder grade 3 or more, and we also analyzed secondary outcomes including 10-year overall and disease-specific survival rates, length of hospital stay, and development of endocrine pancreatic insufficiency.
Can you explain the result briefly?
EUS-guided ethanol ablation was associated with a significantly lower rate of early major complications. Late major complications occurred more frequently after surgery, with no significant difference between the groups. The length of hospital stay was significantly shorter in the EUS group, and endocrine pancreatic insufficiency was less common after EUS-EA than after surgery. Both treatment modalities showed comparable 10-year overall and disease-specific survival rates. Dr. Park, can you give more comments to the listeners?
Our study is the first propensity score matched report comparing EUS-guided ethanol ablation and surgery in patients with non-functioning small PNETs. EUS-guided ethanol ablation was associated with fewer major complications, including newly developed endocrine pancreatic insufficiency, whereas it displayed a similar overall survival rate compared to surgery for the treatment of non-functioning small PNETs. Selected patients may benefit from this method, particularly in those who may be suboptimal candidates for surgery. Interestingly, during follow-up, the 29 patients showed local recurrence after complete ablation. In the surgery group, distant recurrence in the liver occurred in 5 patients. None of the patients who underwent surgery demonstrated local recurrence. The determination of complete ablation in EUS-guided ethanol ablation depends on radiology examination, not pathology result in this study. Therefore, although the image shows complete ablation, there is a possibility that remnant viable tissue may exist. Even though it has a low complete ablation rate and complication rate, local control of the tumor may be still benefit patient as no distant recurrence occurred in our cohort. And the 10-year disease-free survival rate compared to the surgery group was not different. There is no standard protocol and dedicated method for EUS-guided ethanol ablation. We hope further well-designed prospective study with standardized follow-up protocol can give more evidence to this field. The active surveillance for small non-functioning penis less than 1 cm is gaining an interest for acceptable strategy. Based on our study, small non-functioning penis with less than 1.5 cm in size and low grade may be good indication for EUS-guided ablation. Therefore, according to the size and histologic grading of a small penis, treatment strategy may be individualized. For this issue, further study may be needed. The long-term survival and cost-effective analysis between EUS-guided ablation and active surveillance in patients with a small non-functioning penis with 1 to 1.5 cm size would be also interesting. Thank you for your listening.